Okay, I hope I'm audible for everybody. And yes, thank you much for the introduction, Regina. I have to thank Regina really for, I've been working with her for a number of years now, both within Cochrane Insurance Medicine and also on other projects, for example, the project on core outcomes set assessment, and it's been a real pleasure. So I hope to continue this successful collaboration in the future. I'm not sure if the Dutch are so special with regards to recommendations, but anyway, we have a history in guideline development, and we also have quite a few guidelines on the topic of occupational health or insurance medicine. I've been involved in a guideline project for the past 20 months. It was on low back pain. So I'd like to really acknowledge my team as well, who've been doing this work with me. Let's see. So guidelines used to be mostly about assisting practitioners and patient decisions for making appropriate healthcare decisions. But I guess over time, this definition has changed a bit, and it's now much more about optimizing patient care. It's informed by good systematic reviews. It's not just about the benefits, but also about the harms. And I think relatively new, it's a new term that's being used in the past 10 years, I think, shared decision making is really something that has come up, and I think strengthens the role of the patient as an equal partner in the sort of the discussions between doctors and their patients. So when we look at the guideline development in the Netherlands, there are basically two groups that work together sometimes, sometimes not. But we have the occupational physicians guidelines and the insurance physician guidelines. And when you look at the, I guess, the diseases listed here, then there's quite a bit of overlap. And in fact, there is also quite a bit of overlap between the work of insurance physicians or occupational physicians, although I have to be careful. I'm neither. So you can, if I say something wrong, you can always blame me for not understanding. But when we look at the guidelines there's a bit of overlap. And so I'll come to a point that I'm going to make later. It's surprising that there hasn't been any collaboration more in the past, but for the past 10 years there has. And so even though there are a good number of Dutch guidelines available in occupational health and insurance medicine, unfortunately the list looks impressive, but it's not very up to date. So there's a really struggle to get funding and people to do these guideline projects. And also, of course, in implementing these guidelines in daily practice, that's a real challenge. Of course, within the context of insurance medicine, the context is changing quite a bit, legislation, and also in some areas, the evidence too. So when do we say a guideline is old? It depends a bit, but typically when the guideline is more than 5 years old, we tend to say as a rule of thumb, it's getting a bit outdated and maybe it's in need of an update. Also, we ask a lot of advice from the professional organizations, and sometimes the guideline development, they're changing. We're doing risk of bias assessments, and if you're a user of guidelines, that does not have effect on you. The guidelines, the recommendations are quite user-friendly, but sort of the machinery behind it is getting more and more complex. So we also provide training for professional organizations like insurance medicine and occupational health. And of course, funding remains a problem. But despite all these sort of challenges, there's also a great opportunity for collaboration. And that's exactly what we did. We were able to get funding through the Social Security Agency in the Netherlands, called the SUI subsidy. And with partnering with the professional organizations, we started a guideline project to update a guideline on occupational health and insurance medicine on low back pain and lumbosacral radicular syndrome. So this is basically the sort of the structure of the guideline development. You have a question that's been posed by all the different actors that are involved in the guideline process, clinicians, but also patients. And then there are different forms of evidence. And although the expert opinion is at the lowest bottom of the screen, the expert opinion is important as well. And the expert opinion is important, for example, especially when we have to translate the evidence towards a clear recommendation. So nowadays, we also have to review the confidence that we have in the recommendations or in the evidence. So we do risk of bias assessment. So that's the whole machinery I was talking about. And of course, this was what Jos was also talking about, evidence to decision framework. We can't just look at the evidence, but we have to place it in context. What does it do for patient safety? Is a particular treatment available in the Dutch context? For example, we came across quite a few publications on the Swedish back school, but it was quite different from what we did in the Netherlands. So that's hard to make that a recommendation in the Netherlands. And so the recommendation is not just about evidence, but it's also embedded, and it also takes on experience. And I guess that in the area of low back pain, we have been quite fortunate because there are quite a few Cochrane systematic reviews on this topic. And the great thing about Cochrane systematic reviews is that they use the latest methodology. They use GRADE, for example. They grade the evidence. They give you an estimate about the confidence that we should have. And that's easy transferable to the latest methods in guideline development, where we also use the GRADE method. So back schools, workplace interventions, physical conditioning. And so these systematic reviews were available for us to use, and we did. So just to give you an example of our guideline, the guideline exists of, I don't know, about 10 chapters, and those refer to about 10 questions. And an important part of that guideline is focusing on the assessment of risk factors for workers and focus on prognostic factors. And so prognosis is quite important for insurance physicians, not just for deciding on interventions, because that's in the Netherlands. That's not a typical job of an insurance physician, at least not the main work. And so prognosis is quite important by itself to give an estimate about the course of a person's functional ability or his capacity, his work capacity. But in this case, and the example that I'm going to give you is that we were able to use those risk factors and prognostic factors to come up with suggestions or strategies about interventions. In the case of risk factors, mostly for preventing the development of low back pain. And when it comes to prognostic factors, mostly about interventions that maintain or restore work participation. So this is what we did. And I'll just give you one example. For example, one of the recommendations was that to consider additional treatment to restore work participation. And then the advice was to look at aspects such as the duration of complaints, effects of previous treatments, but also, as I just mentioned, the risk or any other prognostic factors or risk profile. And so this looks quite simple, but there's quite a sort of a lengthy explanation afterwards, which I'm not going to show you. But in the case of physical prognostic factors, and it speaks for itself, the recommendation was to provide physical exercise in a time contingent manner. When there were any workplace related risk factors, then the treatment intervention should be about including some kind of workplace oriented therapy. including intensive physical exercises. And when there were psychological factors at play, then cognitive behavioral therapy was advised. So in this way, we try to include information from risk factors and prognostic factors into the recommendations for interventions. Now, I've only been talking about guidelines in the area of occupational health and insurance medicine, but some smart people came up with the idea that maybe it would also be a good idea if we try to improve healthcare, that also the medical specialists would pay attention to work participation, because we know from qualitative research that patients want answers from their specialists. So in 2011, a guideline for guidelines came out for medical specialists. So these are orthopedists, neurologists, for example. And it said, look, you should really pay attention to social functioning, including work. The question, of course, is, how do you do that in guidelines? So I think for main part also the Dutch occupational physicians, they wrote, in collaboration with other actors, they wrote a blueprint in 2005, which was updated then 5 years later. And the blueprint was agreed on by the medical specialists. And the blueprint was called Work Participation in Guidelines. And I think this is quite a revolutionary a paper or guidance, because it basically said that if relevant, that's a disclaimer, a medical specialist should pay attention to work participation, in particularly to recovery and retention of work participation, to the effectiveness of work participation, and also estimate or assess the possibilities for work functioning. So I think if this would happen in all medical specialist guidelines, this would be absolutely fantastic. And it also makes sure that through the whole disease process of patients, there's attention for work. And that's, I guess, several projects in the Netherlands, not just guidelines, but are trying to incorporate this aspect of work in the clinic. So one could ask the question how effective this guidance is. Well, I guess it was effective. There was an assessment between 2007 and 2012, and in 45 of these medical specialist guidelines, an occupational physician was present, and a little bit less, half of these cases, also an insurance physician. So maybe for a start, this is a good result. I think at the time of this blueprint, there was quite a bit of attention. I think that has lowered a bit. And certainly the experience is that even though everybody acknowledges the importance of work participation, it's sometimes difficult for medical specialists to really prioritize these clinical questions about work participation. But we have some very good examples of recent guidelines with recommendations on work participation, and you can see a few of them below. So what are the experiences of medical specialists with the guideline, with the blueprint? Well, to be honest, so the implementation may be better, and so maybe it's really time for another implementation study, because even though we were quite successful of getting these questions or to address the importance of work participation, quite a few of them, the medical specialists, were not familiar with the contents of this blueprint, of this guidance, even though the importance of work participation was acknowledged. And this was 10 years old, so at the time they also saw a problem with the evidence, and I think this may become lesser of a problem over time as the amount of evidence is really is getting better and better. Anyway, coming back to guideline development in the Netherlands, you may be interested to know that our guideline project of 20 months cost the the SSA, the Social Security Agency in the Netherlands, more than 100,000 euros. And that was just for one update, really, of a guideline, a combined multidisciplinary guideline. So it's quite costly and also quite resource intensive, because we had to employ 2 persons. We had a steering group, a project group, many stakeholders, and that meant also a lot of input, which was fantastic, and many revisions. And on the other side, I think the positive thing was that we had little trouble in getting consensus between the professionals, because everybody was involved. So we had neurologists, orthopedists, physical therapists, patient representatives. So we think this should help really with implementation as well. And of course, we think that the project was a success, and we really need to update a lot of these other guidelines for other conditions and diseases. And maybe we should collaborate more on international level, because a lot of these guideline projects are taking place, and at least the evidence base of these guideline projects are mostly the same. Maybe placing them into context in your own country is maybe different, but the evidence should be the same. So enough work to be done. And if you want to have any information on these guidelines, and I'm sorry, they're in Dutch, but we hope to publish, for example, our new guideline soon within the English journal. Thank you very much for this presentation.